Good afternoon, ladies and gentlemen, and welcome to the last session of this workshop. It will be dedicated to pre-exposure prophylaxis against HIV, and it will focus on resistance, but we will also have presentations on medical aspects and social aspects, as well as we will discuss in a roundtable discussion issues of access and financial aspects. My name is Stephan Dressler. I'm a member of the European AIDS Treatment Group and also a member of the program committee of this conference. And I thank the organizers of this conference to involve community members at every level of this conference. We will start right away with a presentation by Professor Dan Kuritzkes from Boston. Professor Kuritzkes is professor at the Harvard Medical School, and he's also chief of the Division of Infectious Diseases at Brigham and Women's Hospital in Boston. He has numerous publications on antiretroviral therapy and resistance, and he has held very many different positions. For example, he has been a chair of the AIDS Clinical Trials Group, ACTG. He's also doing peer review for journals. He is on editorial boards. If I would give you a comprehensive list of all his activities, I would use up at the time of his presentation. So I suggest we start right away, please. Dr. Kuritzkes.
Hello, I'm Dr. Daniel Kuritzkes from Brigham and Women's Hospital in Boston, Massachusetts. And in the next few minutes, I'm going to be giving you an update on the problem of drug resistance and PrEP. These are my disclosures. Here's an outline of my talk. I'll discuss concerns about PrEP and antiretroviral drug resistance, provide some data on the incidence of drug resistance in the setting of PrEP use, talk about the effectiveness of PrEP against drug-resistant virus, and the potential for resistance with long-acting PrEP, and then some conclusions. By way of background, we know that oral PrEP is highly effective at preventing the transmission of HIV, but concerns have been raised about resistance in the setting of PrEP, particularly because drugs used for PrEP are either the same drugs or in the same class as those used for antiretroviral therapy. The selection of drug resistance after PrEP failure could therefore compromise the efficacy of future antiretroviral therapy for patients in whom PrEP fails. Overall, the prevalence of pre-existing drug resistance could also be increased by the use of PrEP. Well, what are the potential risks for drug resistance? PrEP regimens could select for drug resistance in cases where PrEP fails. Intermittent adherence could also allow infection to occur during a time when a patient is not taking PrEP, and then inadvertently be receiving suboptimal antiretroviral therapy when a 2-drug or 1-drug PrEP regimen is reinitiated in the setting of unrecognized HIV infection. PrEP could also select for transmission of resistant variants from partners with failing treatment or pre-existing drug-resistant variants, despite the use of PrEP. And long-acting PrEP formulations raise new concerns regarding the possible selection of drug-resistant virus. What do we know about resistance to common PrEP drugs? Well, drugs currently approved for PrEP require only a single mutation to confer high level of resistance. In the case of tenofovir, that's the K65R mutation. And in the case of emtricitabine, that's the 184I or V mutation, which also confers resistance to lamivudine. The low genetic barrier could be mitigated by the fitness costs of resistance mutations. We know that there is a low prevalence in virus populations of these mutations in untreated persons. And some mutations, such as the M184V mutation, increase susceptibility to other drugs, such as tenofovir, and may actually counteract the problem of resistance to FTC or 3TC. In addition, high tissue concentrations might provide an added pharmacologic barrier to emergence of resistant virus. What about antiretroviral drug resistance after PrEP failure? A systematic review conducted by Gibas and colleagues identified nearly 700 participants with HIV seroconversion in 13 PrEP trials that used either TDF monotherapy or TDF together with FTC. 77 of these were individuals who had acute infection at the time of enrollment into the trials that was diagnosed retrospectively, and more than 600 had incident infection during follow-up. Drug resistance overall was infrequent. It occurred in 18 of 77 participants with acute infection, nearly a quarter of them, but in only 3%, or 19 out of more than 600 participants with incident infection. So very clearly, the risk of drug resistance is greatest in PrEP when PrEP is given to people who are already infected but not yet diagnosed. If we look in more detail at resistance in acutely infected participants in PrEP trials, 15 of them had resistance to FTC with an M184V or I mutation, one of whom had actually received placebo, so must have acquired infection from an already resistant virus. 2 had resistance to tenofovir alone with the 65R mutation. 1 had received only TDF, and 1 was receiving TDF and FTC. And 1 participant had resistance to both FTC and tenofovir, and that person was receiving the combination of TDF and FTC. Continuing to look at resistance in PrEP trial participants now with incident infection, 15 of these had resistance to FTC. 4 were actually receiving placebo, so must have acquired resistance somehow after being in the trial, or because they received a resistant virus, transmission of a resistant virus. And 1 was receiving tenofovir alone, so hard to explain in these 5 individuals where the 184V might have come from. 2 had resistance to tenofovir with a K65R mutation, and again, both were receiving placebo, so must have had transmitted resistance. And then 2 had resistance to both FTC and tenofovir, and both were receiving the combination of TDF-FTC. This slide summarizes case reports of drug resistance after PrEP failure, and this is again from that same systematic review by Gibas and colleagues. And you can see that across these 6 reports, there were actually a variety of mutations in addition to mutations at the 184V and K65R sites that suggest that there may have been transmission of other resistant viruses, or that perhaps in some cases individuals had other exposure to antiretroviral therapy. Now, one of the concerns about current PrEP regimens is that there are high rates of K65R after first-line treatment failure in certain settings, particularly in lower and middle-income countries. In a study that we did at McCourt Hospital in Durban, South Africa, nearly 70% of patients failing a tenofovir-containing regimen, first-line regimen, had the K65R at the time of resistance testing. Another study of 1,000 patients conducted by our colleague, Dr. Brij Kumar, in rural or semi-rural KwaZulu-Natal, of 1,000 patients initiating first-line ART, found a 30% prevalence of K65R at treatment failure. Of course, if these individuals transmit those viruses to their partners, that could be a problem if their partners are using tenofovir-containing PrEP. Looking at tenofovir resistance more broadly, the TenoRes group published in The Lancet 4 years ago this survey, and you can see that many of the individuals in whom tenofovir resistance was detected also had coexisting mutations conferring resistance to other drugs, either to FTC and 3TC by presence of the 184V mutation, or mutations that conferred resistance to the non-nucleoside RT inhibitors, or both. And you can see those in the salmon, red, and green colored bars by different region. Now, of course, the K65R mutation, although considered primarily a tenofovir resistance mutation, itself also confers resistance to FTC and 3TC. More recently, the CDC published, I'm sorry, not the CDC, the HPTN published results of HIV drug resistance in US MSM, and you can see that the range of resistance rates varied quite a lot by region, being highest in the southern United States, where more than half of individuals in Birmingham, Alabama, had pre-existing resistance, whereas 20 to 30% in other parts of the country had pre-existing resistance. Some of these, most of these were people who were all known to be HIV infected, but may or may not have been on antiretroviral previously. They were not on antiretroviral therapy at the time of this survey because they were all viremic. The majority of them had testing for integrase inhibitor resistance as well, but not all of them. You can see that INSTI resistance was relatively uncommon compared to resistance to the nucleosides and non-nucleosides. Well, what about the efficacy of treatment of PrEP if there is pre-existing resistance? One study done in macaques looked at a SHIV, that is a chimeric virus that had the HIV reverse transcriptase in an SIV backbone, into which the 184V mutation had been introduced. And you can see that when those monkeys were given a TDF-FTC combination PrEP regimen, all 5 of the control animals became infected, but none of the treated animals became infected, suggesting that this combination remains highly effective in preventing acquisition of infection despite the presence of FTC resistance. Well, what about the efficacy of PrEP in the context of a K65R mutation? In this set of experiments, again, the same idea, SHIV with a 65R mutation introduced into the RT gene. Monkeys received either intermittent FTC TDF PrEP or control and were challenged with a low dose of this mutant virus. And then those that remained uninfected were, after a resting period, challenged with a higher dose. What you can see is that while the monkeys were still protected against acquisition of infection when receiving only a low dose challenge, TDF-containing PrEP was less effective at protecting these monkeys when a higher dose challenge was used, suggesting that the 65R mutation was impairing the efficacy of PrEP. What about the risk of resistance with long-acting PrEP? Long-acting formulations offer the potential advantage for PrEP of infrequent dosing and perhaps better adherence, but the long half-life and extended tail of these formulations carry unknown risks of exposure if the individual is exposed to HIV during a very prolonged tail. Similar concerns may pertain to the broadly neutralizing antibodies with an LS modification that likewise gives them a very long terminal half-life. This slide shows just how long that half-life can be with cabotegravir given by single injection, and you can see that drug is still detectable out to nearly 1 year. Well, we know in the Atlas and FLAIR studies, in which the combination of cabotegravir and rilpivirine were given as treatment, that among individuals failing on that combination regimen, that cabotegravir resistance can be selected, as illustrated in these individuals from the initial reporting of the Atlas and FLAIR trials. We also know that in the case of long-acting rilpivirine, which is no longer really being pursued for PrEP, that an individual who had received a rilpivirine injection and then had an exposure to HIV 40 days after that injection became infected with a virus that carried the 101E mutation selected by the continued presence of rilpivirine and needed to be put on a different regimen, non-NNRTI containing, because of the acquisition of resistance. We also know that in the non-human primate model, if the monkeys are challenged with SIV, then given cabotegravir as a single dose a few days after infection, that these monkeys can select cabotegravir resistance, as shown in these data coming out of the CDC. So in conclusion, PrEP may select for drug-resistant virus. To date, the incidence of resistance has fortunately been low. The greatest risk is for persons with unrecognized recent infection who initiate PrEP. FTC resistance seems more likely to emerge than tenofovir resistance, but dual resistance has occasionally been reported. The increasing prevalence of K65R after first-line treatment failure may blunt the efficacy of combination TDF-FTC PrEP. And the prolonged tail of long-acting formulations could pose an additional risk for resistance in persons infected after stopping PrEP. More data will permit better modeling of the risk-benefit ratio of PrEP with respect to resistance. Thank you very much, and I will return this to the moderators.
I would like to encourage the audience to submit any questions by using the Q&A button on the right side of your screen, please. We will pick up questions later when we have the roundtable discussion, but you can submit them already and during the presentation is going on. I would now like to welcome Michael Moyle. I would now like to announce Milosz Parczweski, Dr. Milosz Parczweski. He is an infectious diseases specialist at the Pomeranian Medical University at Szczecin, Poland. He's also a clinical virologist. You have seen his presentation on day number 1. He is also vice president of the Polish Scientific AIDS Society, and he has recorded a presentation on clinical aspects of PrEP as he cannot join us in person. Can we have this presentation, please?
Welcome to this session on the PrEP and resistance in the roundtable discussion on the challenges of widespread PrEP in Europe. So I would like to focus slightly on the clinical aspects and general perspective as well. So if we talk about HIV and PrEP targets, we have to remind ourselves the specific targets for Europe, where we wish to have a few million of people on PrEP and reduce the incidence of HIV by 75% from the 2010 baseline. But there are several barriers to implementation. And if we focus on the clinical barriers, you can have it divided from the perspective of the countries where you have PrEP unavailable and PrEP available. So if you would look and review this slide, you can see that one thing is visibility, then there is a fear of resistance, which actually is now less and less important, then the issues of adherence, transmission of STIs. So we have to think about these issues in the context of the implementation of PrEP and barriers to it if we would like to open this discussion. If we would like to look at the medical barriers to the PrEP delivery, on one hand, it's still being perceived as too much medicalized. So where you can have PrEP only, where you can have PrEP to be only available in one medical facility, or you have to go to the medical facility. And actually, there is still discussion on the engagement of the medical professionals. And now I think it's less and less important because we know that many people have shifted the ideas on PrEP, and the medical society is getting used to it. So these barriers are really being overcome. If we would like to open this discussion, we need to still think about the challenges, not only for us medics to work in sometimes hostile environments, especially in the Central and Eastern Europe. Obviously, cost and accessibility, availability across formal medical and more informal platforms, access to prescription, and now COVID-19 epidemics, which has shifted our ideas very strongly. From our medical perspective, We need to balance between immediacy and the need for rapid PrEP, and the PrEP which needs to be initiated as soon as again feasible for the patient to know that they will be protected very, very quickly, and patient safety. So this is why these guidelines which we have are actually speaking about negative HIV test, STI diagnostics, renal function, hepatitis B, and it's consistent across all the PrEP guidelines, where you need to think about some needs, about some things which need to be done. On the chemsex, which is almost in many countries very closely integrated with PrEP, we need to think about the drug-drug interactions, increase of STIs, adherence to PrEP, and whether it will be event-based or continuous PrEP. But we have to think that chemsex and the recreational substance use actually are not interacting with none of the PrEP options very strongly. Obviously, these other effects which people worry about are related to bone and renal issues, and now with the new PrEP options, it will be more open. So I think the discussion can be also rounded around implementation of staff-based PrEP in Europe, and the costs which will be of issue, especially for us in the Central and Eastern Europe. And also we have to think about now, because the epidemics of COVID-19 will be here for significant periods of time, and we have to deal with these reductions of the testing services, provisions of condoms, lubricants, counseling. So I think PrEP now medically can be actually very strongly moved to the online PrEP, online consults, also online platforms. So we have to respond to the COVID-19 epidemics and the issues related with that. And also PrEP is opening the STI risk issue discussion, and this discussion is open for all the time. But please remember that for many countries, PrEP use and PrEP implementation medically on one hand increases the risk of STIs, but on the other hand, this risk is balanced with systematic diagnostics and screening towards the STI. And just to show you this example, this is the underdiagnosis of gonorrhea in Europe, where majority of diagnoses are being done in the West. And center is actually quite happy that there is no gonorrhea, which is not true. There are no dedicated programs, and PrEP can medically help with that. And obviously we have some challenges with chronic hepatitis B and PrEP, lower GFR, aging population, lack of functional kidneys, pregnancies where the partners are on PrEP. So we deal with these cases on the daily basis, but I would like to open this discussion for everyone on PrEP and future of PrEP from the context of the resistance.
Thank you very much for this presentation. I think our next speaker, Meulbroek, will address some of the aspects Milosz mentioned in his presentation. Let me shortly introduce Michael. Michael was born in the Netherlands, but he moved in the early 1980s to Barcelona, Catalonia. And he became, after he was diagnosed with HIV, one of the co-founders of what is now one of the largest community-based organizations in Spain. Later on, he became a co-founder and the first president of the Barcelona Checkpoint, which is a community-based center for the detection of HIV infection and other sexually transmitted infections. They serve, if my information is correct, about 6,000 and more persons per year. And they offer, for example, were one of the first non-medical settings which offered rapid HIV testing. Michael will now give a presentation on social aspects of PrEP, and he will later join us in the discussion.
Good afternoon, and I would like to thank the organizers to invite me to talk about the challenges to widespread PrEP in Europe and the social aspects of that. So as a start, I want to mention the ECDC report that figures that 500,000 men would want or need PrEP in the European Union. And the longer the delay in access for PrEP, the more HIV infections will occur among them. So the question is, how do we increase PrEP access, demand and interest? And how do we increase provider willingness and integrate PrEP into the health center system? So I want to mention 3 points. First of all, let's get rid of the risk assessment checklist. Let me show you 2 examples. First one, the guidelines of the European AIDS Clinical Society, which was the first guidelines in 2015 that included PrEP. But now in the latest version of October of this year, we can still read that PrEP should be used in adults at high risk of acquiring HIV infection when condoms are not used consistently. So the wording is still the same as 5 years ago. Also, if we look at another example, the impact trial, where you can see that the criteria are being HIV negative, have had condomless sex in the past 3 months, etc., etc. So a lot of criteria. Let me give you another example of the Glasgow conference this month where we saw a case presentation about an HIV negative man who requested PrEP, but he has a male partner who's HIV positive for more than 2 years and has an undetectable viral load. Now the question to the public, which are healthcare providers, is what do you recommend? 1, no PrEP, or secondly, daily PrEP with TDF, on demand TDF, daily or on demand with TEF. And here you can see that 58%, so 6 out of 10 said no PrEP. Now, one of the physicians mentioned, well, if somebody comes to me and asks for PrEP, he will have his reasons for that. So we have to bear that in mind. It is true that we have a need to be more cost effective on PrEP, and we want to reduce the impact on the budget and limit PrEP only to MSM at highest risk. But if we talk about comprehensive HIV prevention, we could also present PrEP as an option to any sexually active MSM or transgender woman, based on whether this person feels PrEP is the prevention strategy she is able to use most effectively and consistently. And then we don't have to talk in these conversations, which most of the times is uncomfortable for the client as well for the physician. Secondly, language and messaging on high risk can be stigmatizing and can be a barrier to the uptake of PrEP. Let me give 2 examples of publication of this year from the FLUX study in Australia, which showed that the use of PrEP was associated with lower anxiety among gay men and transgender women. The other study also talked about the change in mental health and drug use among MSM in the UnPrEP study in Amsterdam. So why can't we make PrEP more attractive to potential users? And we can also focus on the benefits in addition to lowering infection risk, like talking about how PrEP can give you less anxiety and peace of mind, that you don't have to negotiate about the use of condoms with your sex partner, and it gives you more autonomy, or the fact that there is no latex barrier gives you more intimacy, or just to improve your sex life, and you don't have to think about acquiring HIV while you're having sex, and that increases also your mental health. Or be part of a bigger project of the HIV elimination, which is a strategy additionally to the U equals U. And thirdly, we should stop talking about risk compensation because it's misleading and it's not evidence-based. So there are no consistent studies that indicate increases in STIs. And I give you two examples. First of all, the 96-week results of the Discover studies, where you can see, except for the first moments, that during all weeks, the prevalence of the STIs were at the same level. Secondly, in the Spanish feasibility study, after 1 year, we could see that the condom use was lowered, and that was statistically significant, but the STIs had a little increase, but none of these increases were statistically significant. So on the other side, what we saw in the Spanish study, that there was a decrease in recreational drugs, and especially those drugs involved with chemsex. And you can see here the numbers of the baseline, and week 52, you see that there was a decrease except for alcohol, and that most of those decreases were statistically significant. So, in a summary, in many places in Europe, PrEP is still not approved, and uptake is still hindered by many factors. PrEP can be beneficial to more groups of population, and to concentrate only on high risk is stigmatizing. We need to reduce barriers and therefore give PrEP a chance to be part of our society. And the bottom line would be, let people decide if PrEP is a valid tool for their HIV prevention. Thank you very much.
Thank you very much for this presentation. Before we enter the roundtable discussion, I would like to introduce Gus Kearns from London to our panel. Thank you, Gus, for joining us. I must admit I only contacted him yesterday afternoon because that was when I learned that Milosz wouldn't be here. Gus is an editor with NAM AIDSmap since, I believe, 2009, and he is also a coordinator of the PrEP in Europe initiative, which is based at NAM AIDSmap. And this partnership is dedicated to increase the access to PrEP in Europe. And you have an amazing coalition of organizations like AIDS Action Europe, you have the European AIDS Treatment Group and many others, and you're also a cooperating partner for UNAIDS and ECTC, I believe. From your experience with PrEP and layout of PrEP, what do you think, where are we? Michael has mentioned in his presentation that we are still short of the doses which would be needed, and we don't reach everybody who would benefit from PrEP in Europe.
Yes. Hello, everybody, and it's a pleasure to be here. Yeah, I mean, I think in Europe, one of the reasons we set up PrEP in Europe, because we realized that PrEP access, and indeed to start off with PrEP licensing, was way behind the USA. And it still is to a certain extent. I mean, I'm now in the country which probably has, maybe with France, the largest intake of PrEP in Europe, and that's about 25,000 people because of the large rollout study we've had. I think it's about the same, or perhaps a little higher, in France, but that's considerably lower than the number of gay men who probably need it, which has been calculated to be roughly equivalent to the number of people with HIV in terms of modeling studies I've seen. And that's not even going anywhere near other groups like at-risk heterosexual women, trans people who aren't part of the MSM community, and other groups. So it's very underrepresented, and in some countries it's still virtually unavailable, particularly over in Eastern Europe, of course. That is officially through the healthcare system. Although one of the remarkable things about PrEP is that we've seen a lot of informal access to PrEP through people buying it online, and then some very remarkable and positive response to that phenomenon by local healthcare practitioners in countries like Poland, where it's not licensed, but PrEP takers are being supported by a network of friendly doctors, and so that's pretty remarkable too.
What are the main barriers, in your opinion, for access to PrEP in Europe? Can you generalize, or would you say it's country specific? Is it a financial aspect? Is it the attitude of doctors and healthcare providers?
People used to say we can't afford it, but there was a whole bunch of cost effectiveness. I've just spent some time looking them up, studies around the 2016 to 2018 period, which just showed that basically once PrEP became generic, once the drug prices fell by 80 to 90%, which is what actually happened after Truvada came off patent in Europe in 2017, then PrEP essentially became cost saving under most scenarios if you give it to people at any degree of risk of HIV. That usually means with a background incidence of over about 2%. So it will save money. Over the long term, you know, you have to, it has front-loaded costs. You have to pay for a PrEP program. So we did get resistance also from clinics, from doctors. Hang on, wait a minute. This is a whole new HIV prevention intervention. We are not geared up to offer a whole bunch of negative people extra appointments. Where is the logistics of it all going to happen? A number of countries objected to that, and still to a certain extent this is a barrier, certainly in Eastern Europe, and I think those are all real barriers, very cash-strapped health services. But also, of course, there is a lot of community resistance that used to come mainly, I think, from within the community, but now I think it's much more, why should we pay for people to take risks and get HIV? They shouldn't be taking the risks. So there is a lot of morality still in there as well.
Thank you. I want to turn the question to Dr. Kuritzkes. It is sort of linked to what Gus just said. When you have resistance and a failure of PrEP, for whatever reason, whether it was an acute infection which wasn't diagnosed and PrEP was started, or whether it was a transmitted resistance and the PrEP didn't work, is that used as a counter argument to implement PrEP widely? I remember, for example, a study of the University of Amsterdam in 2015, so when limited data was available, that healthcare providers and doctors did not have confidence in PrEP.
Yeah, there have been a number of modeling studies that have been done that really have come down on both sides of this question of whether PrEP use, particularly if it encouraged unsafe sex and was accompanied by a selection of resistance, might actually be more harmful than beneficial, because you then potentially increase the pool of the circulating resistant viruses, which would have knock-on effects on the efficacy of antiretroviral therapy. But I think that those models have been somewhat alarmist and have not really corresponded to what's been observed with the use of PrEP in the field. And I think particularly since our treatment regimens today are so robust, and since we know that at least with current PrEP, the most common resistance is to FTC and 3TC, and that even in the setting of that single resistance mutation, a triple drug regimen would still be highly effective. that I'm not so concerned about resistance being a sufficiently worrisome to reduce our use of PrEP, and I still think PrEP overall has many more positive benefits in terms of limiting the spread of the HIV epidemic than potential risks. The one caveat there would really be in lower and middle income countries where monitoring for treatment failure is done less frequently than it is in Europe and in the United States, and where resistance testing is not so widely available as it is in our setting. And that's where we could potentially get into trouble.
Thank you. I have two questions with respect to the long-acting cabotegravir. One question comes from the audience, from Kirsten White. She thanks you for the data review, and how are we going to know when the PK tail of long-acting drugs is no longer a resistance risk? Can you shortly answer this question,
Yeah,
please?
sure. So great question. Unfortunately, I think we'll only know once we have experience and more data. The HPTN 083 study is certainly looking carefully at that question, but we don't have any resistance results from that trial yet. And so we'll have to see what the data show.
Yeah, the question I have is HPTN 083 preliminary results have shown a PrEP failure, obviously, when somebody missed the injection time point and was coming in 2 weeks late. So we are in a situation where the PrEP environment is probably changing in the next years. We will have more options. But will these options necessarily mean that PrEP, medical PrEP, becomes easier? It's a question to you, Dr. Kuritzkes, and then I would like Michael to comment on this question as well, please.
I think that as with almost any kind of treatment, having different options for different people is a good thing. There are some individuals who are still going to prefer taking oral PrEP, whether it's daily oral PrEP or PrEP on demand, as in EPIC-A. And there are people who are going to prefer having injection. In theory, injectable PrEP may be easier for people, particularly adolescent populations and particularly adolescent women, if the 084 study bears that out, where adherence is a big challenge. But I think the biggest advantage of having both injectable and oral PrEP is that people will be able to choose what best suits their individual circumstances.
Yeah, I completely agree on that. I think that the choices, different people, different choices, that's one of the key factors. We have to see injection every 2 months or maybe a pill every month. That sounds really a great option. But on the other side, if people taking daily oral drugs, we are very confident with giving these drugs. And in the practice means that people will come in twice a year. And if you have like injection drugs, it should be 6 times a year. So there are pros and cons, and for sure, a choice for everybody.
Thank you. I would like to ask about the current situation with the COVID-19 pandemic. How does this currently affect the rollout and the take-up of PrEP? I can describe shortly the situation in Germany. We were, so to say, finally ready for rollout of PrEP when COVID-19 hit. And PrEP is more than just handing out a prescription, right? So you need to have a face-to-face consultation. You need to take a detailed history. You need to find out pros and cons. So this delayed because there was less capacity to do so. Would you, maybe we start with Gus because I know he has another commitment. How would you evaluate the impact of COVID-19? Milosz has also alluded in his presentation. Gus, can you start, please?
Yes, I think we have seen programs delayed, as you see in Germany. I think in some countries, EATG did a very good series of surveys on this for Europe at large, and there's been a couple of UK surveys by Bash. Basically, I think some countries that are only just getting actual national rollout together abruptly stopped it. In some countries, access has been made a lot more difficult, and people are but equally there's been a good response by a lot of NGOs who have put on sort of inventive schemes for getting PrEP to people when their clinics have closed down because they're totally preoccupied with COVID. So there's been more provision by community pharmacies, but also a lot more provision described as other, which basically means people switching to getting PrEP online and from friends. I think if COVID had happened a year earlier, it would have been a much more serious situation because PrEP was less well established within the community.
May I ask Michael and Dr. Kuritzkes from heavily affected countries as well, what is the situation with COVID and PrEP? Maybe we start with Dr. Kuritzkes.
Yeah, so in the United States, I think it's been mixed. So we have, for people already on PrEP, there's been a really strong effort to use virtual visits or telemedicine to be able to continue the regular check-ins and to do online renewal of prescriptions. It's been more challenging, especially for us in Boston in the springtime when we were really shut down, to have people come for their regular visits where we do important health screening, especially for other sexually transmitted infections, as well as to ensure that people have not become HIV infected in the interim. There was, I think, a fall off in new starts of PrEP. People who might have been considering PrEP and then may not have already had a relationship with a provider, were either reluctant to get engaged or had more trouble getting engaged in care because of all the upheaval related to the COVID crisis. Now that, at least in the Northeast, the situation is much better under control than it is in the rest of the country, things are coming back more towards normal, but we're certainly still going to see disruptions in other parts of the United States.
So there is a strong regional impact as well. Michael, what is the situation in Spain? You also have heavy regional differences.
Yes, very much. Actually, PrEP was approved on the 1st of November, so it's exactly 1 year ago. And after that year, you know that we have 17 autonomous communities which may decide their implementation. I must say, after 1 year, it's actually only implemented in Madrid, but just by one clinic and in Catalonia. All the others communities, there's hardly access or no access at all. We had in March and April an absolute lockdown, and that meant that a lot of those clinics who were delivering PrEP to people really shut down the medication to the people. We decided to send people medication, to send an HIV home test. We thought probably we can't do STI testing, but the most important thing is that to see if people are still HIV negative. And that's what we have developed a protocol now for the second wave in which we are starting. And we heard just yesterday that the other STI clinic in Barcelona has closed down, and we're not sure if people are getting PrEP or not getting PrEP. It's really uncertain and not clear at all for the people. No information at all.
Mm. Yeah, I've got an addition. Yeah, there's only one clinic in Northern Ireland, and that was closed last week. So basically, in places where there's only one clinic supplying PrEP, it's very vulnerable to changes due to COVID.
So there could be a disruption of services, and that could be probably the worst thing that happens for people who are already on PrEP, right, Dr. Kuritzkes?
Yeah, absolutely. Probably not as concerning if they're on oral PrEP. It's worrisome because they won't be protected. That's certainly a worry. But in terms of a resistance perspective, if they're on oral PrEP and the half-life of the drugs is relatively short, then it's not as much of a concern. And of course, cabotegravir is not yet approved and available for PrEP. But yeah, it is a concern if we're unable to continue providing treatment or preventive services for people. It's very worrisome.
I have to go, I'm afraid. I'm on another Zoom call about PrEP trial designs. So anyway, it's been great. Thanks for asking me, Stephan, and lovely to see a bunch of my colleagues who I haven't seen for far too long. Thank you.
Thank you very much. We are at the end of this session. I asked you, Michael and Dr. Kuritzkes, do you want to add anything, or do you want to emphasize something which we missed? Then this is the moment. If not, I would, Michael, go ahead.
No, I just want to mention, I think it's what we talked about resistance. I think it's very important to have a control 1 month after starting PrEP. That's when you will be able to get any acute infection which were missed at the screening point. Normally, if we do an adequate screening, we will catch most of the infections and acute infections. But I think that's one of the biggest problems with when people buy online. So it's very important to have a good health service where people can be controlled at time.
I completely agree, and I guess the only other comment I would make is that we worry about resistance with treatment, but that doesn't stop us from treating people with infection. It's appropriate to worry about resistance for PrEP, but that shouldn't stop us from using PrEP to prevent infection.
Well, thank you very much for your statements and for your presentation and for participating in this discussion. I hope you stay healthy, and maybe we have next year a face-to-face meeting. I would like, before I close this session, to hand over to Francesca, because we have still some awards to forward. Francesca, are you here? We have to wait 1 more minute. I take the opportunity. Yes. Oh, Francesca, there you are. It's yours.
Thank you. Thank you, Stephan. Thank you for everyone. So I think it was a very big pleasure to be online for this 3 days meeting. It was really successful, and we will present now the Ricardo Camacho Awards. I'm waiting for seeing the slides.
Francesca, people are seeing the slides.
Because I don't see. Excuse me. Oh, okay, it's pity I don't see, but okay. So just to remember Ricardo Camacho. Ricardo Camacho was the head of the virology laboratory in the hospital Edgar Moritz in Lisbon from 1994. And as you know, he left me and all of us lung cancer in 2018. And under his direction, his lab became the main AIDS reference center for Portugal, which contributed for several European projects. And his main fields of interest were HIV-1 drug resistance in non-B subtypes and also HIV-2 resistance. Ricardo was scientific committee member of this meeting since the beginning, and we all remember him as a passionate man, passionate for science and the people he interacted with. So we all decided since last year that fits the best oral or poster that are awarded for his name. So I'm just to remind that we have selected the best oral abstract presentation, and you see that the prize will be the free registration for next year meeting and €500 travel event. And the winner will be I hope you see, because I'm sorry I don't see, unluckily. So the winner is Mohamed Hakatib, that is a PhD student in our University of Rome, and yesterday did a brilliant oral presentation on the symposium of COVID that we did last night, yesterday, from 8 to 9. It's a brilliant satellite, and Mohamed presented an abstract about the comprehensive assessment of SARS-CoV-2 key genetic elements, single or in cluster, underlying geographically dependent genetic evolutionary adaptation and their impact of drugs binding affinity and immune escape. So congratulations, Mohamed, and all the group that did this work. And so I think it was very nice that even if unluckily, we are all fighting against this pandemic, and we managed to do our workshop thanks to virology education, to all the people that participated, that moderate, and Gendel and Ravi that were the leader of this meeting, and all the moderators, participants. We had more than 200 participants, and yesterday the poster tour were very nicely conducted. We were like normal situation. In some cases, we have more than 30 participants for the poster, and we have a lot of nice discussions. But hopefully, of course, we will meet again for the organizing committee to see when we can do next year and where, and hopefully, really, we can do a face-to-face meeting. So I thank all of you for the participation, brilliant talks, brilliant posters, and sorry, this year we didn't provide the best poster because we did not all, so there were many votes, but two different posters. So, but for the oral, the majority selected Mohamed, so it was clear that the best oral was to him. So thanks to all, and Goda for the organization of this virtual meeting, and all of you for the attention. I wish you a nice evening, Shabbat Shalom, Jonathan, and a nice weekend, and hopefully to see next year face to face. Bye bye.